Hello, everyone, and welcome to a live stream of the Aging Together podcast, Season 4, sponsored by Heart Mobility, revolutionizing those steel metal gray grab bars from the 1960s with their newest product, Safety Grab. If you're tuning in live, please use the chat to introduce yourselves and ask any questions along the way. Our guest today will answer them at the end of the show. Today's guest is Dr. Joy Poskozim. She is the dental director for several nursing care facilities, educating staff as well as providing care to nursing home residents. She also makes house calls in and around the Chicagoland area. Dr. Poskozim has been in private practice for 26 years, practicing integrative health general dentistry at her office in the northwest side of Chicago, and has been performing dental procedures on the homebound for over 16 years. In 2017, she earned her dentistry in long-term care certificate from the University of the Pacific Dental School, her fellowship with the Special Care Dental Association Geriatric Council in 2018, and is certified as a dementia practitioner as of 2021. In 2025, Dr. Joy became an adjunct professor at UIC Dental School. All right, and we're back. We're going to try this again. Hello, everyone, and welcome to a live stream of the Aging Together podcast, Season 4, sponsored by Heart Mobility, revolutionizing those steel metal gray grab bars from the 1960s with their newest product, Safety Grab. If you're tuning in live, please use the chat to introduce yourselves and ask any questions along the way. Our guest today will answer them at the end of the show. Today's guest is Dr. Joy Poskozim. She is the dental director for several nursing care facilities. My goodness, my puppy is making the most amount of noise in the background. She educates staff as well as providing care to nursing home residents. She also makes house calls in and around the Chicagoland area. Dr. Poskozim has been in private practice for 26 years, practicing integrative health general dentistry at her office on the northwest side of Chicago, and has been performing dental procedures on the homebound for over 16 years. In 2017, she earned her dentistry in long-term care certificate from the University of the Pacific Dental School, her fellowship with the Special Care Dental Association Geriatric Council in 2018, and is certified as a dementia practitioner as of 2021. In 2025, Dr. Joy became an adjunct professor at the UIC Dental School. She is a 1990 graduate of Marquette University and New York University College of Dentistry in 1994. She completed a GPR from Woodhull Medical Center in 2000, where she was awarded Resident of the Year. Dr. Poskozim, thank you so much for joining me today.
Oh my gosh, it's my absolute pleasure. Thank you for having me.
So to get started, let's just tell everybody, I know I read your fantastic bio, but what do you do? What is your passion? Where did this passion for older adults come from? Kind of walk me through your journey as a dentist.
You know, it's really unbelievable. When I first graduated from dental school, the biggest thing was at the time was cosmetic dentistry. And all these awesome materials that we could be working with to help improve people's smiles. And I really thought that's what my career was going to be about, in doing veneers and having had braces for 4 years as a kid. I really wanted to help improve people's smiles, just from a general practice point of view, not necessarily from an orthodontic point of view. And then I bought my practice in 2006 and get bombarded that Thanksgiving from my two aunts, my grandma's two daughters, asking me to help grandma because she was only drinking Ensure for Thanksgiving because she was left with one tooth. She had been seeing a dentist in the area, about 10 minutes from my practice. No big deal. But it was getting too difficult for her to go to them anymore, and she really liked them, but it was getting too difficult. Could I do something for her? Turns out I could in Illinois. I can practice as long as, I could practice on Illinois soil is actually how it's phrased in the Illinois Constitution. So I did go. And I made her a lower partial denture, and she went to church that Sunday. There was a senior ladies guild luncheon, and she announces to everybody there, over 120 women, that I make house calls. So that was interesting. I got a phone call from my Aunt Mary, frantic, saying, "Oh my God, Joy, I must have given your number out to 5 different families, 6 different families." And they all called me the next day. And the first one that I went to was a woman who had suffered a stroke, and she was nonverbal. She was paralyzed from the neck down. She had a G tube, but the local hospital had said, please keep her mouth clean. And I'm like, woo, go hospital. But it's been 2 years, and the granddaughter called because they didn't understand why her mouth was smelling bad. So I go there and I discover that she's got 2 dentures in her mouth. She's got an upper complete denture and a lower complete denture. And so she had no teeth. And they've been brushing these very realistic dentures for the last 2 years. And what it really comes down to when it comes to oral care in our mouths is we don't know what we don't know. So if you learn nothing from this podcast, know what's in your loved one's mouths, because it's so important that, that information can be shared when it's necessary. They couldn't believe it. The daughter, the granddaughter, the rest of the family who was there could not believe that they did not know. She was a widow, and she obviously kept this secret close to her detriment, because now she had thrush and she had other issues that in her mouth that were taken care of eventually, but could have been completely avoided if she just filled in on, the information. And that was a real turning point for my career. I pivoted 90 degrees, because I'm like, well, what about the home healthcare agency? What about the nurse that comes in twice a month? And they didn't look in the mouth, even though they're supposed to. They instead asked the family what's in the mouth, and they said, no, those are her natural teeth. And that's all that was done. And I'm like, oh my gosh, here's my advocacy right here, right now. And so thanks to my gram, I am now been doing this, like you said, since 2008. And it's been incredibly rewarding experience.
Grandma's to the rescue. Always eager to put us out there.
Seriously, right? She was my first marketing coordinator. Hilarious.
I love that. I love that so much for you. I have so many stories I could share from working in the hospital setting for almost a decade now. Oral care, oral health is a big part of the inpatient occupational therapy team's role. And we always want to make sure people are taking care of their mouths to prevent things like pneumonia and bacteria and all that kind of stuff from getting into their lungs and heart and all of that. And it's always shocking when, you walk in at 3 p.m. and they're like, yeah, I haven't brushed my teeth yet. And you're like, you ate 2 meals and you slept an entire night and you still haven't brushed your teeth, and then you ask, you're like, do you brush your teeth at home? And they're like, yeah, every day or multiple times a day, depending on how they are, and it's just not top of mind. And I think a lot of people don't understand the implications of that, right? If it's a day or two, sure, but for those people who end up being there for a week or multiple weeks or months, if they're not getting proper oral care, you're going to start seeing a lot more issues, things like, infections and pneumonia and just all these different things. And, I spoke with another dentist seasons ago about, the risk of gum issues and how that impacts your overall health, right? And so can you touch on that a little bit, kind of the science behind how poor oral care can lead to other health issues?
Absolutely. When we are looking just at, so there's 2 different kinds of bacteria in the mouth. We have aerobic bacteria that cause cavities, and then we have anaerobic bacteria, the ones that don't bring oxygen, that are between our teeth and our gums. The aerobic bacteria, otherwise known as strep mutans, and you heard that correctly, strep as in a cousin of strep throat, mutants as in mutant strains. So that's the reason why we can't, when I see a cavity, I can't just prescribe you an antibiotic and say, you're good, you're cured. The only quote unquote cure would be, if caught soon enough, a filling, or worst case scenario, root canal, or even a more worst case scenario, the worst case scenario would be an extraction. We actually have to remove the source of infection, which is a tooth. And that's exactly what a cavity is. A cavity is a bacterial infection. Strep mutans will invade the tooth, and it will continue, like a termite, will continue to bury itself and burrow itself into the tooth until it gets to the nerve. And that's a huge problem. because all the nerves are interconnected. So if it gets to that point, then we have a real problem on our hands, aka sepsis. We definitely do not want a blood infection, and that infection being the bacteria that causes cavities, because that is 100% completely avoidable. So that is problem number one. So how do we get to that point? Well, it comes down to nutrition. What are we eating? What are we drinking? And then how are we taking care of ourselves to remove the excess foodstuffs that we didn't digest at our meals? And once again, if we're having something that's really, heavily carb related, well, that breaks down into sugar in the mouth, and the bacteria are like, woohoo, feast. And they're going to start eating the foodstuffs that weren't digested. And a lot of times, sugar is sticky. It will stick to the teeth. And so the bacteria will now start penetrating into the tooth. Bacterial invasion, bacterial infection, cavity. And that's what we're always trying to prevent. We want to make sure that we find these cavities as soon as possible so we can get rid of them as soon as possible, so our immune systems aren't fighting off the bacteria in our mouths. They're now more focused on our vital organs like our heart, our lungs, and our brains. The other type of bacteria, anaerobic bacteria, is the bacteria that causes gingivitis. And gingivitis, itis, chronic inflammation. Gingivitis is the number one cause of chronic inflammation in the world. And very much like diabetes, it is 100% asymptomatic until we start to see either bleeding gums or we start to get loose teeth. And once the teeth get loose, I don't care what country you are in the world, we don't have a way of saving teeth once the tooth becomes loose. Once that gum tissue has deteriorated and once the bone underneath that gum has resorbed, that bone doesn't come back. That gum doesn't come back. We cannot build bone vertically. We just can't do it. So, and they've been trying since 1969. And so that's a problem. That's a real problem. And so we see a lot of tooth loss with diabetes, for example. In fact, the American Diabetes Association recommends that anyone who is a type 1 or type 2 diabetic should be seeing their dentist or dental hygienist for a cleaning 3 times a year, not just twice a year, because diabetics are slow wound healers. And also, too, I can mention that we now know that one of the main causes of gingivitis is this bacteria called P. gingivalis. And we now know, too, that this bacteria is very transient and moves very much, and it can travel to the heart. But more importantly, in the latest research, which has been defended, it can cross the blood-brain barrier and help produce the plaque deposits that we experience in the brain. And I think it's kind of ironic that it's called plaque, because dental plaque is bugs, poop, and food. Arterial plaque is bugs, poop, and cholesterol. And then brain plaque is unfortunately the amyloid proteins that our brains will develop for those that are beginning to live with Alzheimer's. All 3 plaques, all 3 bacteria, and one of the major components of the bacteria is oral bacteria. So if we take care of our mouths, we're taking care of our brains. We're preventing problems, we're promoting brain health. We're promoting heart health. And with the lungs, like you were mentioning with pneumonia, over 85% of bacterial pneumonia is oral bacteria, period. End of statement. So if we're brushing our teeth, if we're brushing our loved one's teeth, if we're brushing our patient's teeth or our client's teeth, we are literally helping out the immune system to counteract the bacteria that we all have in our mouths. And the immune system can be strengthened with brushing our teeth on a regular basis.
Yes, that is a lot of information and education that I feel like most people don't know. And I'd say even the people, like those of us who work in healthcare, don't always know the relevance or the relationship between the mouth and the rest of the body, right? And when you think about it, we do, because we know like everything that we put in our mouth that goes into our body is, related to the entire body or relevant to the entire body's function. But I think it gets lost when we think about stuff that stems from inside the mouth, right? And we don't necessarily always connect to that. So thank you for walking everyone through that, because I think that's just so important. And, one of those things of like, again, when we walk into a room in the hospital and we ask them to brush their teeth or if they've brushed their teeth and they're like, well, I'll do it later. Oh, it's not a priority. And it's one of those things of like, you're in the most like bacteria infused environment you could possibly be in. And the first thing we should do is make sure your mouth is clean, right?
100%.
It's just funny. It's so funny when, you have to explain that. So Since we're on that topic, you mentioned how you first noticed that there was this huge gap in oral care or dental care for those older adults, especially those who either no longer have cognitive capacity to tell you, or those who may have speech impairments and may not be able to tell you, or those who are, have simply been, for a lack of better term, neglected. And, the staff or the providers don't know, or the families don't know what's in their mouth. Talk us through a little bit about, what that experience has been like, just identifying all of these different issues that you've noticed, whether that's in someone's home or if that's someone who's been living in a nursing facility.
So I think one of the interesting things, I'm saying this politely, is that there is no requirement for oral care education, either for certified nursing assistants or for nurses, at least in the state of Illinois. And because of that fact, even though oral hygiene is not specifically listed or defined in the activities of daily living, or ADLs, is supposed to be assumed under toileting, that because of that fact, they don't have to get cited. They won't get cited if I find, for example, oral neglect. Now in Illinois, I've been learning, because I've got 2 cases right now that I'm dealing with, and I've learned that it's oral neglect by omission, because they are aware that the mouth has to be cleaned. It's not that they are not aware, but they're not doing it anyway. And if a person doesn't complain of mouth pain, then there is no problem in the mouth, and therefore they're perfectly fine as is. We don't want to rock the boat and create a problem. And that, when I say create a problem, I mean, in quotes, I'm meaning that, if we're brushing their teeth and the gums bleed, now we've created a problem. And it's actually quite the opposite. Caregivers become very fearful when, first of all, in working with the mouth, they're afraid of getting bit, and they don't know what they don't know. And so along with that, there's fear, okay? Their fear of doing something wrong. And I'm constantly telling caregivers and nurses, I'm like, look, these are older people. They have old dentistry in their mouths. If something happens, if you see something, say something. 100% it's not your fault. But, let's get to the bottom of this. Let's figure out the why, the how this happened, so that I can fix it. If I don't know about it, I can't help. And I can't help this person, and this problem can get worse. For example, if a denture breaks, that happens. I was in a conversation this morning with one of the care directors for one of the homes that I go into. She sent me a picture of it, and fortunately this denture can be fixed. But he's got Parkinson's, the patient has Parkinson's, and he dropped it in the sink. This happens. This is nobody's fault. But fortunately, the caregiver was astute enough to see to see that this had happened, and recognizing, of course, that it wasn't her fault, but that, that we have to do something for him, because now he's potentially has failure to thrive because he can't eat. If we don't have teeth, we have a lot less chance of being able to eat. And that is a huge problem. Another problem, too, is that without brushing the teeth, all of a sudden foods doesn't taste as good as it did before, because our secondary taste buds that we have, not just on our tongues, but in and around our mouths, they can't sense our foodstuffs. And now all of a sudden everything begins to taste bland. And if for those people that are, nonverbal, they're not able to express that. And so now there's a potential for them to stop eating what they would normally be eating, or stop, eating like, breakfast or whatever, because they can no longer taste the food because their mouth is not clean enough to enjoy it. And that's a huge problem as well. So it's not just our immune systems that we're fighting for. We're also fighting for, for trying to prevent failure to thrive. And a lot of times, if someone is beginning to lose weight, another common cause would be potentially cancer. So I get called in after all the blood tests are done, making sure they don't have anything medical. And now they're looking at the mouth. And all of a sudden I go in there, and I, in the past, have seen a raging abscess, dental abscess, or I've seen, in the complete opposite, I've seen a broken partial denture that no longer fits the mouth, and therefore because of that fact, they can't use it, and therefore they're not eating as well as they used to. And food nutrition starts with the mouth. So by learning what's in the mouth, by understanding what potentially could be the problem in the mouth, we can save a lot of these problems, and potentially saving money for the home, from doing all these unnecessary blood tests when the reality is they broke a clasp off, a partial denture, and I can get that fixed within 24 hours. So, it's stuff like that. It's lack of knowledge of dental terminology. It's lack of knowledge on what dentures are and the different types of denture. It's lack of knowledge of what is actually transpiring in the mouth. Their oral exams and dental exams are two completely different things. Oral exams is when there's a tongue depressor on the tongue and you're looking straight back in the oral pharyngeal area. You may be looking at the roof of the mouth. You're not looking at the tongue, you're not looking below the tongue, and more specifically, you're not looking at any of the teeth or lack thereof to know what they are actually eating with. So my question is, how can we develop an appropriate meal plan if we don't know what they're chewing with? So, for example, are they going to be eating regular diet, mechanical soft, pureed? How can that really be determined minus the dysphagia factor? Okay, so we've got that in the mix, completely understandable. But how can we really choose a meal plan if we don't know what is in the mouths to begin with to be able to masticate the food for it to go down appropriately for our residents, our patients, our clients to get the appropriate nutrition they need?
Yeah, I think there's so many layers to this because, bouncing off of that last fact that you just said of, how do we determine an appropriate meal plan if we don't know how they eat or what they're eating with? And that is in conjunction with, their speech assessment, like, right, their swallowing assessment, like, can they
Absolutely.
swallow? Do they have dysphagia? No, let's say the speech language pathologist says, like, hey, they're good, no dysphagia, they can eat whatever they want. So they put them on a regular diet based on any other issues that are restrictions or dietary needs that they may have. Now, all of a sudden, they're sending them these hard to eat trays that are high in protein or whatever it might be, right? Potassium control or heart healthy or whatever it is. And then the patient doesn't eat it. And they're like, oh, the patient's not eating. And then the patient, maybe they ask the patient, like, why aren't you eating? And they might say, oh, it's hard to eat. So now they automatically get placed onto a soft diet. But the soft diet is also like with the mechanical soft, right? And the mechanical soft diet doesn't always help, or it doesn't always include all the other dietary restrictions or needs that they might need. And I'm speaking on this from experience because my grandmother had a stroke last August, about a year ago, and she was in rehab after, and they had her on a diabetic and low potassium diet, which is hard, right? Already as it is. But then on top of that, she's vegetarian and doesn't eat eggs. And then on top of that, she wears dentures. And so it became such a difficult task, even with me advocating for it. I was there and I was trying to advocate for it. And even with that, it became so difficult to get her the right food tray during the meals. And then it turned out she was just getting the same thing every day then. Once they figured out what
Yeah,
it could be, she got the same
absolutely.
exact meal, lunch and dinner every single day, the entire time she was in rehab. So ultimately, we started bringing in food from home. But that's because we were able to, and we knew kind of what she could eat and what she wouldn't eat and all of that, right? But you think about how many patients don't have that support system and don't have access to advocacy in that way. And then, bit of a tangent, but just
Not
issues
at
with the
all.
mouth lead to so many other issues then. And like you mentioned earlier, failure to thrive. And then automatically they become a failure to thrive case, which then gets addressed in a completely different way than a non-failure to thrive case, right?
There's a lot of cultural aspects to what you're talking about. One of the homes that I go to has a significant Jewish population. And, there's a problem, there's, certain people that want to make sure that all their food on their plate is kosher. Total respectable, right? That is their belief system, and we should honor that, right? However, if they're nonverbal and or if they are beginning to get confused because they're in early to mid-stage Alzheimer's, or they're beginning to be a little bit more reactive because they have Lewy bodies dementia. It's difficult then to be able to communicate, and if you don't have that family support to say, we think this is the reason why, he's not eating, then they're going to go through the whole battery of everything else and potentially even, and I hate to say it, force feed. So, because I've seen that too. And they're pushing the food away because they don't know for sure that this is the food that they culturally want to be eating. And I totally respect that. But that's something we also should be taking in consideration, because I've
Right.
seen it. I've seen that happen too. So there are a lot of factors when it comes to stuff like this,
Yeah.
And I also would think too about, when I look at regular diets versus mechanical soft and then, versus pureed, please tell me if I'm wrong, the nutritional value of said foods potentially decline with these quality of foods. Would you say that or no?
Yeah, I think depending on what the food is, for sure. Absolutely. I mean, and then everyone just gets, tapped on with a Ensure.
Yeah, exactly right.
That's what
Which my
happens,
grandmother
right?
could
Everyone
not
gets,
stand.
yeah, like, and that's what they started supplementing my grandma's meals with was glucerna because she wasn't
Mm.
getting enough food and they were just sending her the same food every day. And then she was like, I don't want to eat this. And so then they would just give her a bunch of glucernas. And it's like, that's not a meal. It's
Yeah,
helpful as a meal substitute once in a while. But if you're going
that
to
it
make that,
exists. Yeah.
right, right. But if you're going to make that her sole meal every single day for lunch and dinner, like that's unacceptable.
100%. I agree with you. Yeah, and it's really interesting too because when in the homes, in the long-term care facilities, whether it be assisted living, skilled memory care, the meal time is one of their biggest socialization times, right? This
Mhm.
is when they are able to communicate the most with their colleagues, with their floor mates, so to speak. And so we want there to be interaction. We don't want there to be distraction on what they can or cannot eat. In fact, I've got a situation today. We've got someone who she's in assisted living. She's not ready to have a tooth removed. It's slightly loose. It only hurts her when she chews. And both the power of attorney and I are like, look, there's no infection. This is not going to hurt her. She's not going to choke on this. It's not loose enough for that to happen. We're just going to, let it go. We're just going to take its course and let's just see what happens because her mouth is immaculate, right? She does a beautiful job in keeping her teeth clean. She's a woman. She's also now diabetic. We have a higher chance of getting loose teeth when we're diabetic, like I mentioned before. Okay, she falls into that. So the care director and I were like, okay, do we put her on a mechanical soft diet? And so I literally responded like 2 hours ago, well, let's see what happens. Are the pros going to outweigh the cons? Because she is a social butterfly. And if she is not
Right.
getting the same food as everybody else, I know for a fact that she is going to be embarrassed, right? So we've got that, factor going on as well. Another situation is I had a patient who needed a tooth added to a lower partial denture. Fortunately, the caregiver was astute enough to see that one of the teeth in her partial denture had broken off. It happens, right? It's old. It's probably over 30 years old. So no big deal, but I had to take it to bring it to the lab. She refused to go to the dining room, I should say, to eat with everybody else because she was missing those lower teeth. And she was able to eat, the regular diet that she's normally eating, but she refused to let anyone see her without those teeth. So there really is
Yeah.
something to be said. It's not just on a nutritional level. It's not just, failure to thrive. There's also a social aspect to this as well, that if we don't have our teeth and we can't smile, then it really is going to have an impact on us socially as well as, mentally and everything else, because she also wasn't going to her chair yoga class. I mean, it becomes a slippery slope. So there really is a
Yeah,
lot to say, not
absolutely.
just about the teeth, but the smile itself as well.
Yeah, absolutely. And I think you mentioned this earlier about, doesn't matter where in the world you are, you can't fix a loose tooth, right? But I think same applies here. It doesn't matter what culture you're from, what country you're from. Mealtime is a cultural tradition and value. And it doesn't matter where you are, people hold mealtime very close to their heart. And so
Hmm.
if they feel that they can't show up to it, in a way that is acceptable to themselves, it's going to impact how they address mealtime. And so it's really important to take all that into consideration. I sometimes help families in identifying a few options for assisted living. If they're interested in going down that route, it's like, okay, what's important to you? And one of my questions is about meal times, right? Like, what type of food is important to you? What type of mealtime is important to you? Do you prefer to eat alone in your room? Do you prefer to eat in a dining room with other residents? Do you prefer to eat in a private room with your family? Like, what is important to you, right? And because that helps identify an appropriate option for you for an assisted living facility, right? And so, yes, meal times, big importance there. We've talked a lot about how, some of the challenges in adequate oral health and care for older adults who are living in institutionalized care. What about those who are living at home? What do you see as, like, other than transportation because they can't get out? What are some other challenges that maybe you've seen or you think are there that prevent some of these older adults from getting or receiving the appropriate dental care that they need?
That's a great question. When people, I'm not promoting one or the other. Everyone is different. We all have our needs. We all have our individual likes and tastes. So I'm not going to promote one or the other. That's not what I do. What I am going to say, though, is that those that are living in a long-term care facility and there's a family member there that maybe didn't get the email that I come into that home and now they see me treating this person, or I'm going to be, I'm wheeling this person or bringing this person into their apartment or room so I could provide them dental care. They're like, oh, I want that for my loved one, right? Unlike people that are living in their homes and they've chosen to stay in place, like both my grandmothers did, I'll be honest with you, if they didn't have the support system of their children, then they never would have gotten the resources. You're literally, for lack of a better word, tethered to who you choose to be your resource for the care that needs to be provided. And if you opt out of that, then you really are losing out on all the resources that these different agencies have that can come to the home. For example, my dad discovered when he needed to have back surgery that Medicare will pay for his toes to be clipped, his toenails to be clipped every 3 months. And then they were able to find someone from the hospital. They had a resource that would come to his house to do that for him. Amazing, right? The same thing with optometry, the same thing with audio, the same thing with dentistry. OT, there's a lot of home healthcare agencies that will do this. But if the families aren't aware of what kind of resources that can be provided for them, then they are at a disadvantage. They really are, unless you have the families that are true advocates in saying, no, I know that this is not right anymore. I know this is a problem. A case in point is when their loved one they thought was normal aging, and it turned out to be that their loved one is suffering from an undiagnosed form of dementia and a lot of repetitive issues, a lot of confusion. So we're thinking Alzheimer's, but not fully diagnosed. And the loved one, a wonderful person, daughter, said, well, she no longer wants to brush her teeth anymore. We don't know what to do. And it turns out that it's not that she didn't want to brush her teeth anymore. She just didn't like the feel and the sound of the electric toothbrush. As soon as I offered her a soft, regular toothbrush, manual toothbrush that I offer to any one of my patients here at my office, she was fine with it. That neural pathway, that memory came back. She took the toothbrush and she immediately started brushing her teeth. So it's that lack of knowledge, those lack of resources that, a nurse or a caregiver who has had experience with other patients, other clients with these issues, that they can share. And that knowledge is really important. And so another thing too that I mentioned is like, well, the person can no longer stand in front of a bathroom sink anymore. So, we just kind of let it go. We think his brushing his teeth on the toilet is kind of gross. Well, I completely agree with that. But you also don't have to brush your teeth in the bathroom. As long as you've got 2 cups, one to rinse with and one to spit with, and you've got a towel over your chest, you literally can brush your teeth in the comfy chair. You can brush your teeth immediately after dinner at the dining room table. It doesn't doesn't matter where you brush your teeth. It's just a matter of then you should be brushing their teeth. And especially even for those that are suffering from mid to, late stage Alzheimer's or one of the dementias, having an action following by another action while they're still focused is huge. So having that toothbrush and toothpaste right on the dining room table and they're having their dinner and then immediately, pushing the food away, they're having their water or whatever they're drinking, ideally water. And now you're handing them the toothbrush. They are still a focused mindset, ideally. And we have a much better chance of acceptance and having those teeth being brushed immediately following the eating activity. And so then it doesn't have to be done at bedtime. It doesn't have to be done 2 hours later when now they've just been kind of sitting in front of the TV doing nothing. And now we expect them to be awake and alert and focused on doing this. That's not fair. Having an action following an action, having, lunch, on the TV, tray in front of the TV. A lot of times too, when I'm there in the homes, the caregiver or the loved one will want to turn the TV off. And I'm like, no. Great distraction. They're focused on this. Let them be distracted by this while I go ahead and do what I need to do, which is look in the mouth to make sure there's nothing mobile, to make sure there's no infection, to make sure there's nothing missing, like a filling or a restoration or a cap or a crown. I can look at the dentures. All while they're still focused on the, watching TV, I can do all this. And so it's not just, so much focus on me and potential fear. Or, if they're not really watching it, at least it's soothing sounds in the background of, let's say I'm making this up, Gunsmoke or whatever TV show they're watching. It really does add a really good distraction for them. And so that I can do what I need to do while that's being done. So there's these little hints, the little tricks of the trade that they don't necessarily know while living in, like in a community setting. But they potentially, once they do learn this and once the caregivers do know for their loved ones that have chosen to stay in place, that one-on-one ratio, well, nothing can beat that. Right. So to have that focus on their person, and to make sure that, they know all these things ahead of time, the better off, their life is going to be because they know their person very well.
Yeah. Yeah. You made a couple great points about care at home. And we're starting to see this shift to the model of hospital at home, right?
Mhm.
And I feel like, so do you work with home health care agencies to go out to people's homes? So yeah, so I feel like this applies to both home care and to the institutionalized care. But a lot of these services are almost seen as ancillary services and not
Mhm.
core services, and I feel like even rehab is often contracted out, right? Even though
Mhm.
rehab is so important, it's often a contracted service. And you see the same when it comes to podiatry for foot care, right? Especially for our patients with diabetes. You see that, like you mentioned, with optometry, all of that. You were probably the first person I met who mentioned dentistry, right? And that's why I was so interested, because I can't believe that I never thought of that, and that also it's not norm, right? And so how do you, get into these contracted roles, but also for families who identify this as an option, how do they advocate for it with whoever their care providers are, whether it's at home or whether it's in a facility?
That is such a great question and a loaded question.
It
So
is.
one of
It
the
is. Lots to unpack.
no, it's all really good though. I am on the lecture circuit trying to teach dentists that once we find out that one of our patients has moved into one of these communities or can no longer go to their practice, that we need to be the bridge, because the nurses, the admitting nurses, the directors of nursing, the ADONs, they are not doing they're not doing a dental exam, and potentially they're not even doing an oral exam. And because it's just lack of knowledge, especially if it's an LPN and not an RN doing the admission, right? Been around long enough. I've seen it. It's unfortunate, but it's true. So what I'm telling now is we as dentists, I'm obviously advocating for, okay, you find out that your patient, Mrs. Smith, is moving into XYZ home, across the city. Have a conversation with the executive director, the director of nursing, the ADON, whoever it may be, saying, look, Mrs. Smith was coming into the dentist 3 times a year for, cleanings, et cetera, for proper continuity of care. By the way, this patient has an upper partial denture. Here's what it looks like. it is so easy anymore to take pictures and to send emails that will take minutes of your time. But so therefore, the nurse who is now doing the admitting hopefully will read said email and be at least be aware of what is in this person's mouth. And so I'm putting the onus back on the dentists and the dental hygienists to say, hey, we're going to have more and more patients that are not going to be able to come to us anymore for whatever reason. We need to put ourselves out there for, 5 minutes of your time to let that home health care agency, that long-term care community, that executive director to know what is in their patients' mouths. And a lot of times too, I'm writing POSs to make sure that this patient has been on prescription fluoride toothpaste for the last 6 years. It really seems to be helping this person. We've seen a major decrease in cavities. Do you have an on-site pharmacy? Do I need to continue to write this script? Will someone else be writing this script? These simple things that we can help, we're being a resource to the nurses, hopefully is looked at favorably, that we're assets and not trying to create more problems or headaches for these nurses, but saying, hey, I'll do it. Just tell me, do I still do it to the Walgreens? Who do I now, write this script to? And I will continue to do so if you don't have a dentist on, that will come in boots on the ground. So there's that part of it, right? And then for advocacy, fortunately, we've got the internet, and you can look up, house call dentists. That's what they're called. There's a wonderful group in California that are called house call dentists. You can look up at-home dentists, or there is a wonderful group on the East Coast called Geriatric House Call Dentists, and they're fabulous. And then there's, I know 2 to 3, 4 different people in the Chicagoland area that do what I do. And we have our own personal reasons for doing it. It's usually a very personal reason that we start doing stuff like this. And we go into the homes and we provide oral care. But I think there is a lot of it has to do with advocacy and education. And as long as we can be helping to educate the home health care agencies, as long as we can be educating the nurses and the caregivers in the nursing homes, and then to really, for the loved ones, to really be advocates to say, hey, I really want to make sure that this is, being done for my loved one. It's not just a luxury. I definitely want this care for my loved one. Fortunately, we're out there online. It's just using the right keywords, I guess. I think one last thing I'm going to say about that is that when we have a loved one that no longer can come into a dental office, we should also be aware, if we're going to be the primary caregiver, of what our responsibilities are, and that the fact that ADLs actually exist, and that brushing teeth is part of the ADLs. And I can't stress that enough, because that's a federal regulation, right? So as long as we are trying to stick with the ADLs, then brushing teeth has to be a part of that. And it is, unfortunately, we all have to be advocates for our own health care. And then we have to be advocates now for our loved ones' health care, whether it be our children or, our parents or grandparents. But to be able to reach out for help, ask for help, and hopefully, to receive help is the best thing that we can do. There's no shame in asking for help. We are just trying to be the responsible adults that we are trying to be as caregivers.
Thank you for taking that leap and starting that. You started this, I think you said 16 years ago, when this wasn't really even, front of mind. I mean, it's still not front of mind. So I can't imagine how much you had to pave the way 16 years ago. And so speaking of that, you still get pushback, and what
Yes.
kind of pushback do you get, especially in nursing homes or assisted living or wherever you might be going?
So you haven't seen my latest LinkedIn post.
I
Anybody who
must have
wants
missed it.
Yeah, it was couple weeks ago, last week. Yeah. Anyone who wants to, discuss with me and consider me a resource, please find me on LinkedIn, Joy V. Poskozim, Poskozim. So yeah, saw a case. This is now the second case in a very affluent skilled nursing facility that I go to. And this person's dentures had not been removed from her mouth in 18 months. The upper denture had not been removed for 18 months. She literally had food on her tongue, which was a choking hazard. The boli of food were unbelievable. And when I did have one nurse, an LPN, come into the room to see what, I'm going to be nice talking about, she didn't know how to do even an oral exam. So she just looked like, and I'm like, okay, well, let me show you how to do it. And I lowered the lower lip and she stepped back like 3 spaces. Like she could not believe what she saw. Once again, we don't know what we don't know. If they're not trained to drop the lower lip to see what's going on in front of the mouth, like the lower teeth and then the access to the tongue, then she would have probably had put, a tongue depressor on top of the tongue, maybe seen the food, maybe not, but unbelievable. And the thing that kills me is the thrush that I found on this denture was once again 100% avoidable. Now, to answer your question, I took pictures, documented everything, and the director of nursing was on vacation, and I love her. She's a fabulous person, which is the reason why I'm still there. So this was under the ADON's watch. So I email the ADON with the pictures, and she said, and I used the term neglect, and she specifically said that I was too harsh. And I said, no, I'm not being too harsh. This is 100% neglect. And in Illinois, I need 3 cases of individuals, not 3 cases with one person, but 3 individual cases before I can let Adult Protective Services know, before I can have an investigator come in. And those are the rules. So be it. I've got 2 now within the last 3 months. And it's unfortunate. But that, this is what I was told, that I was too harsh. And so then when we spoke on the phone, she again said, because she said it in the email and then she said it again on the phone. And I stopped her. I said she could have choked and the thrush could have been avoided. I said, I put her on, nystatin for 10 days. I'm still speechless in the way that I was talked to in my findings for this patient. There was no clean toothbrush for her. The 2 toothbrushes that were in her top drawer of her bedside table were disgusting. And what were they doing there? They were literally collecting dust. She had no toothpaste. It was unbelievable. And fortunately, the sons, she's got 4 sons, 2 come out on a regular basis. They had heard me talking, because I've got a loud voice, down the hall with another resident the month prior, and they set up the appointment for me to see her. So it wasn't even because of something that they personally had seen, that the caregivers or the nurses had seen. And I still never even met the caregiver that dressed her that morning to say, hey, do you know how to brush her teeth? Do you know how to take her denture out? I can show you. I was never introduced to that caregiver. So I don't know who's taking her denture in and out every day. I know she can't brush her own teeth. I know she can't put her denture in or take it out at night because she does have an undiagnosed dementia. But I'm going to do a spot check and see how she's doing. That stuff, the nystatin, she's on for 2 weeks. I'm going to wait and see. Like another 2 weeks, go back when I see some other residents and just see how she's doing and see if she's got any more buildup again. And I truly hope not. So yeah, so I've still to this day get pushback, even though I've been going to this home for a very long time and have had really good results with a lot of families being very grateful for the treatment that I do. And I'm not trying to pat myself on the back. I'm just saying there is a lot of good that has been done there in oral care. And yeah, it was tough, very, very tough for me to deal with. I can't hear you. Okay, let's see. I can't hear you.
It just randomly stopped working. I don't understand.
I got you.
I just wanted to say I applaud you for standing your ground and calling it out for what it is and what it was, because I do feel like ancillary services, right? All of us who are not physicians or nurses often get told that we're being too harsh. And
I believe you.
I feel like, and it's one of those things where it's like, I feel like it's a respect thing or a disrespect thing for the most part. But I think a big part of it is just the lack of awareness and education of what our role is in the entire holistic care, right?
I agree with you on the disrespect, and she was so condescending to me. And she may be slightly, maybe within 5 years older than me. So maybe she's got, maybe 5, within 5 more years of education than I do, or experience, I should say. But don't tell me something about my profession that you obviously know nothing about, and you knew nothing about this case, right? And she's like, well, we're not used to getting pictures of well, then maybe you need to step into the room every once in a while and make sure that this person is being appropriately taken care of. I'm sorry.
Yeah.
I don't want to sound like I'm going off on a tangent, but it is just so frustrating. And I'm sure you get just as frustrated when your knowledge is rebuked or put down, or you're being condescended to because of the lack of the knowledge that is on the other end of that conversation. Do you know what I mean? And how do
Yes.
you maintain that
Yes.
professionalism? And, what's the saying? You want to be the better person, right? You want to step above that, lean in, continue to do, do the good fight, right? Fight the good fight. But it was completely astonishing to me that the lack of knowledge that she had about, this particular person, that she didn't even know this person had an upper complete denture. Well, that was supposed to be part of the admission process. There's literally 5 questions on oral care alone. So, and once again, I wasn't blaming her personally. I was just saying, this is the situation. And she's like, well, so then I got a follow-up email saying, well, now there's a care plan involved. I'm like, great. I'm thinking to myself, she's been living there for 18 months. I'm glad to know there's a care plan now. Fantastic. If oral care was considered part of the ADLs, that would have been included on day one. And this is an accredited home. So anyway.
Right.
Yeah, I'm sure you
Right.
go through it
I
too
mean, I think,
on a regular basis too, and it really makes me upset because we're just assets. We are resources. We are assets to their community. We're not trying to step on their toes. We're not trying to do anything like that. If anything, we're supposed to make their lives a little bit easier by saying, "Hey, let's look at this. Let's take care of this. This is what this is. I can make this better. We can make this better. Let's work together to do that." And then to get the pushback from that person is like, "Whoa, why?" Yeah.
yeah. We could go off on a tangent on this because I've had certain residents in the hospital who, they think that they have so much authority and can talk to you however they want to. And I have to kind of, for lack of a better term, like put them in their place and be like, listen, I know you've got 4 years of med school under your belt and now you're a first year resident, but I have 10 years of experience on you.
Seriously.
And it's like I understand that you're concerned from a medical standpoint and the medical background on this, but like here's everything else that is impacting this, or here's everything else that matters, and yeah, we could talk about that for days.
One more thing,
I
and
can
I just want to say one more thing regarding that. A lot of times I'll get called too because the MD has diagnosed thrush. Fantastic. Good on oral thrush. Good on you. That's awesome. But they prescribe the
Anything.
medication, the nystatin, the biostatin, whatever, as if it was somewhere else in the body. For the mouth, it has to be 10 days. For another area of the
Mm.
body, it's 5 to 7 days. And so I'll get called when they've been on the biostatin, let's say, for 7 days or 5 days for that matter, and it's not working. Well, that's because they didn't prescribe it long enough for oral thrush. Do you see what I'm saying? And so now I'm coming in and I'm like, well, no, let's prescribe it for another 72 hours. And the doctor's like, well, what good is that going to do? And I'm like, well, that's proper protocol. And considering it was just DC'd yesterday and I'm coming in today, I think we're within the limits where we can do another 72 hours and it's going to go. And they're like, sure. And guess what? It's this lack of knowledge. Good on you for recognizing that it's thrush. Fantastic. Good on you to prescribe the nystatin. Nystatin. Awesome. But sometimes, the dentist or, OT, my God, you're a doctor too, for Pete's sake. We do have a body of knowledge that potentially the MD, the DO does not have. And once again, we're resources, we're assets. We're there to help, not hinder, your patients, not to hinder treatment for, our residents, my residents. So, yeah.
Right. And our job is not to make your life harder. It's just to
Yeah.
make sure that the patient is getting all of the care that they need.
Well-rounded care. 100%.
Yeah.
Yes.
I cannot believe we're at the top of the hour here.
I
But I have a few more questions that I would love your insights on. So
Go
maybe
for
a
it.
little bit of a rapid fire here.
Yeah.
We've talked about, so these two questions kind of go hand in hand, but we've talked about, how much of all the challenges and opportunities in institutionalized care. There was a report out last year that over 850 skilled nursing facilities shut down across the country. There's another report that we're going to see a lot more shut down in the upcoming years, especially as more and more adults choose to age in place, age in home, and then also all of the cuts to our healthcare benefits that are coming up too. So and alongside the second part over here is, with that question, like, what do you foresee how do you see this like improving or growing pains, or kind of just like how do you see this care model change with this decline in skilled nursing facilities and more adults aging in place? And then also, aligned with that, if you could wave a magic policy wand What systemic change would most improve the quality of life for these adults and those who care for them, specifically related to dental care?
I'm going to answer the second part first, and that's that required education in dental terminology and dental exams and dental care. If we use the term oral care, we use the term oral health, I think it's too vague. I think we really need to be specific and say dental care, and it has to be required learning. It could be a 3-hour seminar. I can break it down to a 3-hour seminar. You will know everything you could possibly want to know about a denture, the different types of dentures, so on and so forth. So education, mandatory education is key, along with mandatory yearly follow-up, because just like any other part of medicine, dentistry, there's always research and development, new things that are going on. For example, dental implants. The majority of the caregivers make a minimum wage. They're probably never going to see a dental implant in their lives, but they should know what they look like when their patients are coming, their residents are coming in with said dental implants. They're not posts. There's a significant difference between the two. So there's my answer to that. So if I wave my magic wand, it becomes part of all nursing education and part of the certification for CNAs. So the first part, if more and more people are going to be moving into or just staying in their homes, that actually might not be a bad thing from a dentist, from a dental office standpoint of view. And the reason why I say that is because then we still will have their addresses. We still know where they live. And we would need to know is what agency they potentially are going to be working with, home healthcare wise, so that we can give that information to said agency, said NP or PA or whomever, so that they know what's going on in their clients' mouths. So that actually might be a good thing. By saying, oh yeah, Joe Schmo moved into a nursing home, we don't know which one that is, or they're moving down, by staying in place, we still have potential access to help them. And that actually could potentially be a good thing. That being said, resources are hard to come by in general, let alone in someone's home. So once again, I also, on the flip side of that, see a lot more need for advocacy and demand for those resources to be able to come into the home so that their loved ones can be taken care of. So I see that home health care agencies potentially could be spread thin because of more and more people choosing or having to stay in place.
Love that. And I hope that you're so right on that and that it'll only make it better for people who are at home. We love a good practical tip or tools. So what is one resource or mindset shift that you wish every caregiver or family member knew about dental health and dental care?
For those that are living with one of the dementias, tell, show, do. I can't express this enough. So for someone who, and you can use this for someone who's 6 or 96, you're not going to say, hey, honey, do you want to brush your teeth? What's the answer going to be? No. So you're going to say, no. It's going to be no, and that's okay. But we're not going to give them that option. So we're going to say, Mrs. Smith, I'm going to brush your teeth today. You show them the toothbrush. You show them while you put the toothpaste on said toothbrush. And then with your other hand, you're going to be pointing. You're going to divide the mouth into 4 quadrants: upper right, lower right, upper left, lower left. And then you're going to use your non-dominant hand, the one that does not have the toothbrush in it, to put a hook in alongside the inside of the cheek so that you cannot get bit. And this works with ALS as well. So, and then you're going to point to that upper right side. Mrs. Smith, I'm going to start brushing your upper right side. And even if she's clenching her teeth, you're still getting 50% of that tooth structure, that tooth surface. And that's still a win. You drop down to the lower right. You tap that outside cheek. I'm going to brush the lower right side now. You cross over the lower front teeth with your fingers so you can't get bit. You hook your finger on the other side, touch the lower left side. Mrs. Smith, I'm going to brush the lower left side. And now we're going to touch the upper left and brush the upper left. Once again, if they're still clenching, I don't care. We have brushed the outside. We can check to see if the mouth has any have they scrolled any food to make sure they haven't pocketed any food. We can do a lot. We can see a lot by being able just to do that, even if we don't even get to see the tongue. So tell, show, do, it's huge. We learn it for peds in dental school, but we've also been able to extrapolate that for people of any age that are unable to brush their own teeth. I hope that helps.
The OT in me loves how you broke that down, and also the very specific and appropriate cueing strategy.
Yay!
Before we wrap up, what's your biggest takeaway that you hope everybody listening to this walks away from after everything you've said today?
It's okay as caregivers to forget to brush a loved one's teeth, right? We have a lot of guilt as potential caregivers, and we have our own lives that we have to deal with. But tomorrow is another day, and you do the best that you can with what you have. And if the electric toothbrush isn't working for you, you use the manual toothbrush. If they're only brushing the outside of the teeth, that is okay too. We take the wins and we focus on the wins. And that is so extremely important. And I think that qualifies for any person of the healthcare industry, the healthcare profession, that we do the best that we can with what we have, with the resource that we have, in order to have really good outcomes for our patients. But like anything else, we just have to be consistent with our own mouths as well as the mouths that we're caregiving.
Yes. We've got one viewer very active in the comments section who would like to share that you have shared some good information here and to eat an apple.
Yes, you bite into an apple every day. It helps speed up your metabolism to start up your day, and it does remove surface stains off the front of your teeth. So if you're biting, it's a great fiber source, and that natural fiber will naturally clean off the surface stains of your upper front teeth. And it's, like I said, it's great for your metabolism to start off your day. So an apple a day keeps the dentist away too.
I love that. Dr. Joy, thank you so much for being here with me today and for sharing all your knowledge with our audience. It was so great having you on the show.
Thank you for having me. So sorry about all the technical difficulties. I appreciate your patience. We figured it out. We figured it out. That's the most important thing.
Yes.
So thank you, thank you, thank you. It was a pleasure.
Absolutely. Absolutely. For those tuning in live, thank you so much for joining us today. I'll be back with another live stream in 2 weeks. Same time, same place. See you then.